Thank you for joining this Friday province-wide rounds. Today we have we're privileged to have Dr. James Lan to give us a talk. And Dr. Lan is currently the director of tissue typing laboratories at the VGH and province-wide, and also an associate professor in the Department of Pathology and Laboratory Medicine, as well as the Department of Medicine. And Dr. Lan is always going to talk to us about his research work on the tissue typing related subjects. Please, James.
Thanks very much, Dr. Gao, and hi, everyone. Thank you for taking the time during lunch to attend this talk today. I hope to discuss a few things today, and mainly the theme is to discuss how we can use precision medicine to improve access and outcomes in transplantation. I'm a kidney transplant nephrologist, and our interest is to take technologies in the lab to apply them clinically and improve outcomes and access. Sorry, I'm going to share my slides here. And just swap the presentation mode. Okay. So I hope to share 3 lines of work that we've been doing in our research group. The first one is that we have developed a novel immune compatibility metric, which has broad implication for organ allocation in general and specifically for kidney allocation. The second is the application and development of real-time molecular mismatch to guide the selection of immunosuppressive therapy and organ allocation. And finally, this is a new grant that's been funded, which utilizes the cell-free DNA to improve post-transplant monitoring for early detection of kidney allograft injury. So the part 1 of the talk is about access and equity. One of the themes about kidney allocation for us is that this is a precious resource. And when we allocate, we have to ensure we use the organs to their fullest ability in terms of efficiency, but also to ensure equity in terms of promoting access, patient access to transplantation. And the common theme here for us is this issue of sensitization. So as one can imagine, when someone experiences a foreign molecule in their system, they can develop an immune response to it. In our world, that forms that really translates into the formation of anti-human leukocyte antigen antibodies. So specifically, women that have had pregnancies before, because of the DNA from the spouse, that they can form anti-ACHI antibodies through that process. The other mechanism that we see is blood transfusions, that when patients are exposed to foreign immune molecules with HLA, they can form anti-HLA antibodies. And these antibodies are harmful when it comes to organ transplantation. So for the most part, we avoid these antibodies. And that has implication on allocation and equity. The metric that we use to measure this antibody breadth is a metric called a calculated panel reactive antibodies, which I'll go into a bit more details. Back in the 1960s, this PRA test was developed as a laboratory test and using local blood donors to represent the HLA composition of the local area. So the example I give here is, as a clinician, when we're trying to assess whether a patient has access to how many of the donors in the donor pool they can be matched to, we take their blood and then we react it against a panel of healthy volunteers. If many of them are triggering a positive reaction, that would indicate that their antibodies are directed against the donor, and therefore they are not matched. They're not well matched because of these antibodies. However, if the cross-match test is negative, that would imply that this patient actually can safely receive the organ from those donors because their antibodies are not donor-directed. But this was a very crude test that was developed in the 1960s, and as you can imagine, depending on where you do the test and where you are geographically, patients can get different results. And this test was modernized to a calculated frequency because over time we know the population frequency of these HLA antigens. And for instance, A2 is a very common HLA molecule that's in 50% of the population. So when someone has an antibody developed against A2, right away their CPRA goes to 50%, meaning that 50% of the donor pool they're not eligible for, that they're anticipated to be excluded from. And in fact, we've gone on to build a calculator in our field. So when we test patients when they come in to be listed for transplant, this is one of the tests that we first do. And this patient has 3 antibodies. And when you put it into a calculator, you find that 69% of the population, they are not eligible for, they will be excluded from. And so this is an interplay of a laboratory test with clinical allocation in transplantation. That it started off with a PRA test, and then it became a surrogate for patients' access to transplantation. And accordingly, what we've done in our field is to assign allocation priorities for these patients, because we appreciate that many patients, they have a large breadth of antibodies, and they become very difficult to match, and we have to help them somehow in our allocation. And the way we do that is to give them allocation points. So in the United States, when patients have a CPRA greater than 80%, you can see they increasingly get more difficult access to transplant, and they get points so that they get pushed to the higher priority when the organ becomes available to them. In Canada, we have a different metric. And when patient CPRA is exceeding 95%, they are defined as difficult to match or highly sensitized. And when that does happen, then we put them into a national pool where they can get organs from anywhere in the country. Outside of this, they would only get organs from their own jurisdiction, i.e. their own province. So this is one of the ways we share organs nationally in Canada. So a few years ago, I had this thought experiment, because this entire organ allocation has been like this for decades, way before I ever joined this field. And I said, well, is CPRA truly a good measure of global immune compatibility? Because as we know, transplantation is not just anti-HLA antibodies. We actually have to consider ABO status as well. In fact, ABO actually was even there before HLA when it comes to immune compatibility assessment. And so I was worried that our field got this wrong the whole time, because we're given priorities only based on HLA, but we completely ignore ABO. So what would the concept look like then? So imagine a patient who is blood type O, and they have 1 antibody to DR53. And when that does happen, currently their CPRA will be calculated by this frequency of the DR53 in the population, which is 50%. But then the assumption is that everyone else in a donor pool would be available to them, which is actually not true, because amongst the remaining pool, only the donors that are blood type O would they be eligible to be compatible with. So in fact, the true immune compatible donor population is actually the HLA plus the ABO, and when we calculate it out, it will be 76% rather than 50%. And that's really the simple concept when it comes to genetic adjustment for ABO and HLA. So I was working with a friend out at Tulane University who is very good with population genetics. And we quickly wrote a formula to calculate the genetic adjustment for ABO. And we went on to publish this paper in 2022. And the concept here is we apply this new metric and apply it to a large data set of patients waiting for an organ transplant in the United States, close to 200,000 patients. And what we're seeing here is that the ABO distribution is very interesting, because depending on your ethnicity, the distribution of ABO blood group is quite different. If we look at Caucasians, for instance, that 45% of them are blood type O, 41% blood type A, and the minority are blood type B. But compared to other ethnic groups, for instance, Asians, the proportion that are blood type B is quite a bit more. And for indigenous population, at least in the United States, that's a little bit different. In Canada, it's actually different from what I have as well too. So depending on the patient blood type, their level of genetic adjustment will be different. And then we apply that to all the waitlisted patients in the United States. And just to give you a idea of the reclassification metrics that we came up with, these are patients currently considered to be very highly sensitized, who are 99%, based on their current CPRA calculation. And when we apply the genetic adjustment to ABO, actually 44% of them should really be considered 100%. And so they were really misclassified by the current system. What's the implication of this? The implication is that depending on the patient's blood type, their level of correction is different. So if currently all the patients were 99.25%, with ABO adjustment, the majority of O and B candidates would actually be crossing the threshold of 99.5% and be considered 100%. Why do we care about this? It's because the allocation is based on their CPRA. So currently patients who are in the United States 100%, only those patients would have access to the national donor pool. Everyone else would be based on their own jurisdiction. And so even though it seems like a tiny percentage when we are doing the correction, it has a huge implication when it comes to their access to the donor pool. And so, well, that was US data. We wanted to understand what's the impact of this in a Canadian situation, in a Canadian context. And there is actually a difference in how we allocate kidneys in Canada compared to the United States. In the United States, they assign kidney allocation based on ABO, identical. So the blood type A patients, they can only get it from blood type A donors for the most part. Similarly for B, O, and AB. But in Canada, we're a little different. So someone who's blood type AB, they can get access to compatible donors, essentially all the blood type in the population. But that is not the case for blood type O patients. They can only get in from the O donor pool. So right away, you can see there's a disparity here if we do not adjust for ABO. And in fact, that's exactly the concept that we discovered here in Canada, that we have been disadvantaging patients in different blood types. So if someone's CPR is 99%, currently they have access to all the blood type donors, but we're treating them the same as someone who's blood type O that only have access to blood type O donors in the donor pool. And when it comes to allocation sequence, we're seeing issues such as the following. You have one donor who's blood type O, and then they're being ranked then on who is more highly sensitized. By the current CPRA, this blood type B patient is considered to be more difficult to match compared to a blood type B patient who has a CPR of 97% based on ACHI antibodies. But when we do the ABO adjustment, which gives a better idea of true immune compatibility, this patient is actually more difficult to match, but the organ, in fact, will go to the other candidate because we have now accounted for ABO adjustment. And so then we model this out using Canadian national data, and we did this about a year ago. And these are the collaborators that helped me complete this analysis. And the first thing we wanted to understand is if we take everybody who are highly sensitized on the national waiting list, and we look back at the deceased donor pool over the past 10 years, what it would look like. And so for someone who has a CPRA of 95%, they should theoretically only match 5% of the donor pool. But when we stratify by the blood type of the patients, we see that that's actually not true. Now, 95% can match 5% of the donor pool is only true for AB patients. But if you look at patients who are blood type O or blood type B, their ability to find a compatible donor is way less than what the metric would indicate. It's only when we recalculate and reclassify patients by ABO adjustment that we see now this compatibility makes sense, that their number of donors that they're matched to actually now reflects their ABO adjusted CPRA. But we know that organ allocation is not a box that's static. It's a very dynamic process because at any given time, new patients are added to the waiting list, and some of them will receive an organ transplant and then they're removed from the waiting list. So what we then went on to do is we perform a discrete event simulation. So we started with the active waiting list of candidates in 2018. And then we basically flew in all the donors that we got in Rio over the past few years. And when they matched, they were removed from the organ waiting list. And when new candidates were added to the list, they would go on as per usual. And then we recorded the number of times that these patients match, and then we took them away from the waiting list. And what we showed was that if we were to allocate kidneys by the ABO adjusted CPRA, that overall more patients would actually receive offers during this time because we're truly giving kidney to someone who's the most difficult to match compared to patients that are inaccurately getting an organ when they're not supposed to. So overall, by using this new metric, the efficiency of kidney allocation would improve for hard to match patients. So where are we going with this concept of immune compatibility metric is we proposed this concept 3 years ago now. our Canadian modeling data is about to be submitted in a new manuscript. I presented this in the United States and elsewhere in other countries as well. The Canadian Blood Services has actually adopted this as the new metric going forward because it would correct a lot of the disparity that we currently have, but that's now been uncovered. And in fact, outside of the kidney, heart, lung, pancreas allocation also uses CPRA. So now these organ groups also want to apply this metric into their system, and we're doing simulations to understand this, what's the impact. We also want to understand what's the actual impact on ethnic disparity. In the US, when they have more African Americans, they would be more impacted by this current disparity. So we're understanding that. In Canada, we have a different ethnic population. So applying this to understand the disparity for Indigenous patients and also Asians, we're kind of looking into this as well. And to me, the most exciting part is when we presented this new metric, a lot of other countries, such as in Poland, Ukraine, Europe, Asia, they said, well, this completely makes sense to them. And they would also like to see how they can apply this new metric. And we are now discussing a new proposal to develop a global ABO-adjusted CPRA metric where any jurisdiction can put in their data set and we would help them build a calculator. And once and for all, we can have one single metric for organ allocation in the world. So that's kind of where that project is heading into. And I'll just switch gears and talk about a different way to use precision medicine to improve access and outcomes in transplant. I know not everybody here is a nephrologist. And so just to provide a context, kidney disease affects 1 in 10 Canadians. Currently, there's 50,000 Canadians living with end-stage kidney disease. I think in pathology, we talk about cancer mortality quite a bit, but the reality is for our patients with kidney disease, by the time they reach end-stage kidney disease and they're on dialysis, half of them will pass away over 5 years. So the mortality rate is exceedingly high. It also takes a lot of money to look after these patients as well too. These are highly complex patients and dialysis care is expensive to provide. And the reason that we love kidney transplant so much is that it's the only therapy that provides both mortality and quality of life benefits. And importantly, it's one of the few therapies in medicine where it actually saves the healthcare system dollars. That every transplant we do, we will save the system $250,000 over 5 years. We do about 1 kidney transplant a day in BC. And in BC, and we're very proud of this statistic that you see here, because I don't know that anywhere else in the world anyone can do this, is that there is currently more patients with end-stage kidney disease treated with a transplant than being on dialysis. You can see the national average, so we're way above that in BC. But what is the problem? That every transplant that we do, despite all the benefits, 30% of them will fail over 10 years. And the main cause of the failure is rejection. And so difficult is this condition, we actually have no proven therapies that can treat patients with antibody-mediated rejection. So although we can diagnose it, there's not much that we can do. The graft will fail invariably over time, and we just get patients ready to either go back on dialysis or to get the next kidney transplant. And so 6 years ago, my mentor and now colleague, Dr. Keong, and I got together and we said, we really need a new way to address this problem in transplantation because our outcomes have been stagnant for the past 20 years. And so we were fortunate enough to obtain a large-scale Genome Canada grant to start a new program that we call the CAN-PREVENT program, which is to use precision medicine to prevent antibody-mediated rejection. And so you can see now this is a Canadian consortium, but we have many international collaborators as well. We got together pathologists, clinicians, laboratories, law, pharmacology, and so on and so forth to form this consortium so we can develop novel solutions to help our patients. And our approach, really the main one, is we remember it's been 70 years now since the first kidney transplant occurred, and it occurred between identical twins. And the reason that was important back in the days, and it had to be identical twins is because they had no immunosuppressive medications. And so they knew back then that if the genes were similar between the donor and the patient, then we don't really need immunosuppressant. But what we do know now is that the immune response is not just directed against the human leukocyte antigen molecule, but the discrete amino acids on the surface of these molecules that we call the epitopes. And so what you see here is that each HLA molecule has very distinct epitopes that can incite the immune response. So the idea here then is, well, can we then quantify the differences in these epitopes between the donor and the patient? And then we can really risk stratify patients and maybe treat them differently. So then we developed this molecular mismatch analysis and try to understand, really, does it associate with the risk of rejection? And we just completed this analysis, including 1,000 patients in BC. All within the past few years, we wanted to do a contemporaneous analysis. And then we analyzed the epitope differences between the donors and the patients and risk stratified them into 3 different groups. Only a minority of the patients, the lucky ones, that happened to be 0 mismatch. And as you can see, none of them had rejection. But in addition to them, there were patients with mismatches, but low burden of mismatch that actually had very minimal risk of rejection as well. And then there were the high epitope mismatch patients, so a lot of disparity between the donor and patient at the epitope differences. And then those were the ones with a much higher risk of rejection over time. And so then we said, well, oh, that's very interesting as a retrospective analysis. But then can we use that information to guide the choice of immunosuppressant? So as you can imagine, we have different intensity of immunosuppressant that we give to patients. And right now, we don't really have a good way to know who should get more or who should get less. And what this analysis shows is that patients who are low epitope mismatch, that it didn't really matter what type of intensity of anti-rejection medications that they get. That even with the most intense or the least, those ones not even treated with prednisone, they actually had very minimal risk of rejection. Only 1 out of 141 patients. But the patients who actually have high burden of mismatches between donor and patient, those patients, then we really need to consider the type of immunosuppressant that we get. And so the patients who happen to be steroid-free, that they didn't get enough anti-rejection meds, they actually had the highest risk of rejection. But if we could actually know a priori who they are and give them ATG, which is our most intense therapy, then the risk of rejection is greatly reduced by 4-fold. So then at this point, we kind of present this data, and then the feedback that we have is, well, is this just a retrospective research, or can you actually implement this clinically? And the answer is, well, how do we want to envision doing this then? So currently, we have about 300 patients on the kidney waiting list, and they could all get sequenced under high resolution using the MiSeq instrument, which is fine. However, as you can imagine, we don't know when deceased donors will pass away and then donate their organ. And when someone passes away, there is no control for us. We have to test them the moment that they decide to donate. And usually we have to do the testing within 4 to 6 hours. So if we wanted to analyze their epitopes in real time, the MiSeq instrument is not going to be able to allow us to do that. So we need a technology that allows us to sequence the donor under high resolution in a very quick fashion. And the breakthrough technology that came is when Oxford Nanopore came up with their sequencer. So I have one here, as you can see. This is a portable MinION, and here is the flow cell. And in addition to being a very portable instrument, what that allows to do is to get real-time sequencing within the span of only an hour and to get the data that we need. Once we have the genotype of the donor, we can put it into a computational pipeline that converts the genotypes into 3D protein structures, thereby allow us to analyze the epitope disparity between patient and donor. Then we take that information and we give it back to the clinician to prescribe medications. When we first mentioned that we wanted to use nanopore for sequencing, there was a lot of concern because of accuracy rates. But over time, the chemistry improved. And as you see here, Karen Sherwood, who is an HLA director in the lab as well, as well as our senior technology team, we completed the biggest validation using nanopore to date. I think right here is 160. Now it's over 200 in our lab. And we put through samples to this technology using the most challenging specimens that we have. So we put in proficiency testing samples, clinical samples known to have problems. Our lab, because we've been using NGS for the past 7 years for genotyping, we detect about 1 to 2 novel alleles never described before for the past few years. We actually publish on these as well too that have been completely verified by independent lab. We put them to the nanopore sequencer. We have rare alleles that we put in as well too. And finally, the buccal swab. So as you can imagine, our lab provides genotype testing to support stem cell transplant. And a lot of their collection is using buccal cells. And buccal cells have a lot of contamination, DNA fragments. They're not the easiest samples to work with. And even then, when we apply all these samples to nanopore, we're able to get 100% accuracy rate under high resolution. So this is at the level that we feel is sufficient high robust to be used clinically to inform care. Then I wanted to understand in real time, if we did the testing in parallel, then how fast is it going to take us to sequence the donor? So Franz is a scientist and director in our lab who sequenced, as you can see, 5 different disease donors. The moment they came to us, we split the DNA into the usual routine workflow and then the high resolution nanopore workflow. And he was able to get from beginning to the end in less than 4 hours. So this is what it looks like now. We have 2 technologists trained using this workflow, and we're about to train up 2 more. We're hoping to launch this by Q3 of this year, so just within the next few months. When we first started, we thought that we needed an hour to do the sequencing. Now we know only 20 minutes, we would have sufficient data to do the analysis. And after the sequencing, we put it into this pipeline to do the epitope mismatch analysis. And then we get the score back. And then we can give it back to the clinician for selection of immunosuppressive therapy. And now we have the GridION. We're getting a second one in the lab, which allows us to really move away from next gen into completely nanopore-based typing for clinical testing. And this is the lab that did the work. Oops. So far we have covered, we can sequence patients and now donors in real time to get really real-time data to allow prescription of immunosuppressant. But the story doesn't end there, because it happens that when we leave it to chance and just allocate organs, the majority of patients are not going to be super well matched. And the problem for these patients is that their safety zone is very narrow. If they're not well matched, we have to use a lot of immunosuppressant, and the risk of infection, cancer, and toxicities, they go up, which then lead us to reduce their immunosuppressant, and all of a sudden they're under immunosuppressed, and then graft rejection and graft loss occurs. So it's very difficult to balance the two for many of our patients. So what we realized is that we want to make a major difference and move the needle on outcomes is we have to go to the very top. Is that the moment when we get the organ, when we allocate it, we have to find patients to make sure they're well matched to receive that organ. Not just that they don't have antibodies against them, that genetically at the HLA structure, we want them to be well matched. And we're then lucky enough to get the second round of funding through Genome Canada, which is allowing us to take that technology and apply clinically within the next 2 years. And that's what we're doing. And these are all the institutions and vendors supporting this next study. When we thought about doing this, there were a few concerns that came up on feasibility. The first thing is, if we have an organ, what is the likelihood that we'll find a well-matched patient on the waiting list to receive it? And so we did a simulation using Canadian data from different sites. And what you're seeing on the x-axis here is the waiting list size across all the jurisdictions in Canada. And what you're seeing here is that even at 200 to 300 size of a waiting list, most of the time, almost close to 99%, that we're able to find a patient on waiting list that they're well matched with that organ. So it turns out that there's a very good chance that for every organ that we have, we can find a home for a patient who's well matched. The second question was, well, are we going to introduce ethnic disparity in our process? So you can imagine an indigenous person, let's say living in Vancouver, where the donor ethnicity is primarily Caucasian. Are they going to wait? Are they going to have a hard time finding a well-matched donor compared to someone who's Caucasian on the waiting list? And so Russ Doyle was a fellow working with me a few years ago, just 2 years ago, and he did this analysis that was presented at the American Transplant Congress last year. We're submitting the manuscript in the next 2 months. And what we found was that the ethnicity of the candidate really did not determine whether they could find well-matched organs, between Asians, non-Asians, Indigenous, and Caucasian, that their ability to find well-matched organs really did not differ. So that gave us some confidence that this is a kind of an allocation strategy that's not going to introduce ethnic disparity. So where we're going forward is we want to prescribe immunosuppressants better. We want to allocate organs better. But what we also lack is a technology to monitor the immune system after transplant. And as Paul Kian likes to say, he says, it's kind of like trying to treat hypertension without a blood pressure cuff to measure the blood pressure. And so we can appreciate the immune system is very dynamic post-transplant. Sometimes it goes up, sometimes it goes down, and we have no way to monitor this. So is there technology that we can use? So Danny is my wife, who visited. This is a picture from 10 years ago, and that's my personal connection to this assay. When she visited me in California when I was in a fellowship, she was pregnant with our first child, and I wanted to know the sex of the child. I just wanted to know so we can prepare for him. And at the time, we realized that there was a technology being developed, which now we know is the NIPT test. And it's based on the understanding that the fetal DNA is basically circulating and can be detected in the maternal circulation. And that can be detected by NGS sequencing. So that technology wasn't commercially available at the time, but I knew this guy on campus, and then we just gave Danny's blood to them, and they were able to tell us that we're going to have a boy. And a few years later, when we had our second child, that technology became commercially available. And then by the time we could pay for it, and also knew the sex of our second child. But when I was, going through this process, and I said, well, organ transplant is very similar because we can also have DNA released from the donor organ that gets damaged, that goes into the recipient circulation, and we can find it by NGS. And so it turns out that that is in fact possible. And a few years after all this, and there's a company that actually started to develop this. And now this becomes a commercially available test in the United States, where they're finding that there's an elevation of the cell-free DNA from the donor that precedes the time of the clinical injury. And in many cases, the donor DNA is elevated in the recipient circulation months before the clinical dysfunction becomes evident. So that was really interesting to us. The problem with this is that that test is now delivered as a central laboratory service through these commercial labs. There's only 3 of them. And if we wanted to use that test, we would have to pay $4,000 Canadian for each test that we get. And so we said, well, how can we bring that test into Canada? And Michael Mango, who is a collaborator in Alberta, and I started talking about this. Then we saw an opportunity to actually apply to our grant. And this is the genomics research, the genomics innovation grant from Genome Alberta and BC. And what we're hoping to do in this process is actually to decentralize the cell-free DNA testing, bring that into BC and Alberta as a pilot site for rest of Canada. And the way we're going to do this is that we'll validate a decentralized test kit that we have in our lab, and we're going to do that through very rigorous validation. And then in the next year, we're going to open this up for clinical testing throughout all BC and Alberta. And the way we would use it is we want to propose it for patients with subacute clinical dysfunction. It's because if patients have evident clinical dysfunction, they should just go ahead and get a kidney biopsy. The routine use of this assay in patients who have stable kidney function is actually not very clear. And as you can imagine, it's very hard to demonstrate a positive clinical trial in a routine surveillance fashion. We are actually currently applying to CIHR. It's under review. We propose a large pan-Canadian RCT to understand this. But currently, we would hope to offer this service to patients who have subacute clinical dysfunction where the creatinine rise is a little ambiguous. And then clinicians anywhere in the province can order this test. We would do it in our lab. If they have an abnormal cell-free DNA test, they should proceed to a biopsy with the hope that they can detect injury earlier than standard of care. Those ones with normal cell-free DNA, then they wouldn't necessarily get a biopsy. They would just continue to be followed clinically. So this is a pathway that we're proposing, and we're hoping to launch this test within the next year for clinical use. So in conclusion, I hope I presented some interesting data for you today that we now can apply real-time genomic technology to more precisely guide the selection of immunosuppressive therapy for transplant patients. Now we're starting to incorporate the genomic technology and precision medicine approach for organ allocation to minimize rejection. And the story doesn't end there because where we want to go with this is to minimize drug in the future. If we can mostly get patients a well-matched organ, then de facto, they don't need a lot of immunosuppressive therapy. We can minimize the drugs that they get and maybe achieve tolerance through a variety of approaches that we're looking at as well. So I just want to thank all the investigators that you see here, particularly Paul Keong, who has really started this Genome Canada Transplant Consortium program, and the other collaborators across the country and internationally as well, and also the VCH group, Michael Smith, CIHR, and Genome Canada as well. So thank you very much, and I'm happy to take any questions that you have.
Maybe I can start, James, by asking a question.
Mazi, please go ahead.
Yeah, thank you very much for you covered a lot of ground and lots of rich information. So in the contemporaneous data that you showed, it was interesting to see that most of the graft loss happens in the first year. And then it appears that they kind of coast along after. So what is happening there? What kind of rejection or what is the cause of graft loss? And would that give you any information in terms of maybe we can think about not only different types of immunosuppression, but maybe increasing tolerance in those patients?
Absolutely. And that is something that has been pointed out by many people, which is actually what we observe. The risk of rejection is the highest in the first year, and they're especially concentrated in the first 3 months. And there's a lot of hypotheses on why that might be the case, but I think the main one is that the immune system after transplant becomes highly upregulated. Ischemia reperfusion, for instance, happens around that time as well too. And so the goal then is to suppress that very turbulent time through better matching or perhaps augmentation of immunosuppressant. Now, we only focus on that first year for the first analysis is because that sets the tone for what happens to these patients later on after the first year. Because when someone rejects in that very turbulent time, usually, as you know, Massey, the treatment is we pile on a lot of immunosuppressant. Now, that might treat the rejection somewhat, but the issue is then they begin to have the toxicities from this immunosuppressant. They start to go leukopenic. They start to get viral infection. And all of a sudden, then we completely withdraw their immunosuppressant and we go way to the other side. And then you constantly go back and forth between those two states. And then the graft is lost then from a variety of reasons. Now, they might lose the graft because they develop BK viremia and BK nephropathy. Is it because they lost the graft from BK nephropathy, or is it because they have rejection in the first place and we give them a ton of medication to suppress that? So it's very hard to then attribute a causal graft failure to BK when the inciting event was rejection in the first place. And so that's why we wanted to have a reset and start from the very beginning and understand if we can do the first part very well, then we can perhaps obviate the downstream effect of all these immunosuppressants and toxicities.
Thank you.
Tyler, please.
Hey, James. Yeah, and I think Gao had to drop off, so I can take over facilitating the Q&A here at the end.
Oh, thank you. Yeah.
That was a great talk. Kind of along the same lines, but in a different direction. My understanding is for monitoring patients' kind of immune status, or at least their, like, you'll do that CAP tube, which will just tell you about TB/NK cells. Has there been discussion about using some of these newer technologies like Andy Wang and company at Cancer Agency have been working on, where you can, have like basically dozens of lymphocyte subsets analyzed at the same time and being able to have some higher level immune monitoring to see some of these trends about rejection before they become clinically apparent?
Yeah, I think that has been investigated extensively for many years. The issue is the specificity. We see lymphocyte counts go up and down for a variety of reasons, but even when they go up, are they specific to the donor is the issue. There has been a lot of attention on, can we use, let's say next-gen sequencing to characterize donor-specific, T cell receptors, for instance, utilization. And there are a few groups working on this still. It has been actually very challenging to do that. The issue with cell-free DNA, although it's very sensitive, is that it does lack specificity. It doesn't really tell you what type of injury that you have. And interestingly, with cell-free DNA, the type of injury that gives you the highest elevation turns out to be antibody-mediated rejection. And so if someone goes way above 1%, we know that probably the risk of antibody rejection is quite high. And then we can add on another test to improve that diagnostic certainty, which is donor-specific antibody testing. So we're starting to use some of these biomarkers kind of combined together to help us improve both the sensitivity and specificity. And so, it's not a perfect test, but we have to learn how to use it. And the fundamental issue that we have is that it has been too cost prohibitive to do, but the ability to do decentralized testing gives that assay back in our hands, and we can make improvements upon the assay and how to use it. Another way to use the assay is actually the circulating tumor DNA. So I know there's people here that work on this test as well too. And what we're actually hoping to do, because many of our patients, they get cancer, they get post-transplant lymphoma, other types of cancer, is that can we use dual tests to monitor these patients? Because usually when they get lymphoma, let's say post-transplant, we reduce their immunosuppressant, then they might have rejection. So we're starting to design a trial where we can actually follow these patients receiving cancer treatment to understand their circulating tumor burden. Is it going down appropriately? And also at the same time, monitor is the cell-free DNA level tracking upwards indicative of injury that's about to happen.
That's cool. Thanks, James.
Thank you.
Any other questions for James?
I actually have another question, but it's more interesting to me when James, you compare the practices here and state, and I'm wondering, I'm assuming there's a trade-off when we go for ABO compatibility rather than identical matching. Is it because we have a smaller donor pool, or what is the trade-off here?
Excellent. I actually have a slide which I took out, but that's an excellent question. Why is it we assign organs differently? The issue of assigning by identical, the benefit of assigning by identical is that they don't have the same disparity, because A is going into A, O is going into O. You don't have that scenario that I pointed out. But the issue is, if you're a blood type A patient and you're difficult to match because of anti-ACHI antibodies, then it might be beneficial to know there's an O donor out there that you don't have anti-ACHI antibody against, and to be able to access that O donor pool. But if you're only going by identical allocation, you will never see that donor. So we actually did it correctly because we maximized the opportunities for these patients that we already said they're difficult to match. But the issue is when we rank them, we didn't do it properly because we failed to adjust for the ABO effect. So we actually think the perfect model is our way of allocation using this new metric that adjusted for the ABO effect. So United States is actually looking at that right now.
Cool, thank you.
All right. Well, thank you very much, everyone, for attending today. And I look forward to getting to know you and having conversations about potential collaboration on projects in the future. Thanks very much.